Hello, everybody.
Today we are going to discuss about Hellp syndrome. So Hellp syndrome is the severe pregnancy related condition which is associated with severe morbidity. It is associated with the maternal mortality rate of 0 to 24% as well as perinatal mortality up to 37%. So it also affects 0.2 to 0.6% of pregnancies, and it has mainly association with preeclampsia. Like if somebody has preeclampsia, then 70 to 80% chances are there that patient will develop Hellp syndrome. And why it is necessary to identify Hellp syndrome? Because it is associated with mortality. By diagnosing it correctly and by managing it correctly, we can prevent it. And also it is mainly occurring to the third trimester, mostly before 36 weeks of gestation. So before knowing anything about health, first we should be aware of what are the risk factors. Because if we know the risk factor, we can identify correctly the population which are prone for Hellp syndrome. So risk factors are hypertensive disorder of pregnancy, maternal age more than 40 years, high body mass index of more than 35 kg, pregnancy interval of more than 10 years, previous history of hypertensive disorder of pregnancy like preeclampsia, eclampsia, then previous Hellp syndrome, pre-existing vascular or kidney disease. It is traditionally been thought that Hellp syndrome is the complication of preeclampsia, as I mentioned before. So now let's see what is pathophysiology. So it is mediated by combination of genetic mutation as well as systemic inflammation, which is mainly placenta derived. So what happens exactly? This impaired placentation in early pregnancy results in ischemic reperfusion injury, which triggers the release of cytokines and other factor, which is inducing the cascade of inflammatory and coagulatory process, including endothelial damage. The coagulation cascade is initiated by adhesion of platelet to activated and damaged endothelium. So platelets then release thromboxane A2 and serotonin, which is causing vasospasm and platelet aggregation, and it causes further endothelial damage. This causes consumption of platelet and hence thrombocytopenia. So red blood cells break down while passing through the constricted platelet fibrin rich capillaries, causing microangiopathic hemolytic anemia, which is another characteristic feature of Hellp syndrome. So because of that, multi-organ microvascular injury has occurred and hepatic necrosis, which leads to the development of Hellp syndrome. So basically, this endothelial damage and inflammatory state in the liver results in sinusoidal obstruction syndrome. So the pathophysiology, if I want to explain in the short, then only two things are responsible, that is endothelial damage and the cytokine storm, which is associated with the inflammation. And then this endothelial damage is responsible for thrombocytopenia and the hemolytic anemia. And then this ischemic reperfusion injury, which is occurring, is responsible for the cytokine release, and that manifested as multi-organ failure. So we'll see what are the clinical features. So symptoms of Hellp syndrome are variable and non-specific, with 70% of cases presenting before 36 weeks of gestation and remaining 30% occurring within 7 days of delivery. So these symptoms include malaise, right upper quadrant pain, nausea, and vomiting. Other features are headache, hypertension, and proteinuria. So rare features that are secondary to the progressive disease include placental abruption, bleeding diathesis in the form of DIC, acute kidney injury, liver hematoma, hepatic encephalopathy, ascites, and liver rupture. So there are two classification systems for Hellp syndrome. So one is Mississippi classification and the other one is Tennessee classification. So according to the Mississippi classification consists of three components, that is platelet count, LDH and AST. So so LDH is always more than 600 and AST for say they are saying always more than 70. So basically this Mississippi classification is divided into class 1, class 2 and class 3 is based on platelet count. So if platelet count is less than 50 per 50,000 then it's more severe, that is class 1. Class 2 if platelet count is more between 50,000 to 1 lakh, and class 3 if platelet count is between 1 lakh to 1 lakh 50,000. So LDH and AST criteria are same. LDH more than 600 and AST more than 70. So the second classification system is Tennessee classification. And the criteria for this is moderate to severe thrombocytopenia, abnormal liver test, and evidence of hemolysis. If all three criteria are present, then we can categorize it as complete Hellp syndrome, and only 2 out of 3 criteria are present, then it is labeled as partial or incomplete Hellp. Now let's talk about diagnosis. So diagnosis, as I mentioned before, if there is a platelet counts will be low, plus there will be the evidence of hemolysis. Now evidence of hemolysis, how can we say that? So if we can diagnose it uh, by by doing investigations like peripheral smear, because peripheral smear will show schistocytes. The hepatoglobin levels, it will be 1.2, that means low. There will be severe anemia, plus as I mentioned before, the liver enzymes will be elevated. So these investigations should be there for suspicion of Hellp syndrome. So female with the preeclampsia, if there are elevated aminotransferase, rising LDH, uric acid, then we can say there is a that the patient is progressing to the Hellp syndrome. And with the help of Tennessee classification, we can say the patient is in complete Hellp or partial Hellp. So as I mentioned before, all three criteria are present, then complete, and if 2 are present, then incomplete. So along with that, we should also know about the differential diagnosis of Hellp syndrome, that is acute fatty liver of pregnancy, which is very close differential diagnosis. And the another differential diagnosis are hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. Now about the management, treatment of Hellp syndrome is delivery after stabilization of the mother. So because why delivery will reverse entire thing, because as we have seen in pathophysiology, the entire thing is driven by the placenta, and the placenta is culprit. So if we deliver the placenta, all the pathophysiology will be reversed. So management can be considered under 3AD, that is stabilization of the mother. Stabilization of the mother mean we have to stabilize her blood pressure. If she is uh, throwing seizure, then we have to treat that. And if you are not planning for delivery, if you are opting for expectant management or conservative management, then we need to give this corticosteroid for fetal lung maturity. For expectant management, the lady should be less than 34 weeks. And the other management options are delivery and the management and the prevention of complication. So for blood pressure control and prevention of seizure is uh, so for blood pressure control, we can use the medications like labetalol and hydralazine. For seizure control, we can do it with the magnesium sulfate. And for fetal lung maturation, we can achieve by using corticosteroid like dexamethasone and betamethasone. So delivery is the ultimate treatment for Hellp syndrome. So if the patient is of more than 34 weeks of pregnancy, then no doubt we have to proceed with the delivery. But if the patient is of less than 34 weeks of pregnancy, then we have to administer, then we can consider the expectant management, and we have to consider by of giving like corticosteroid for the lung maturity. So why expectant management means why we should consider the expectant management when the definitive treatment of the Hellp syndrome is delivery. So it is saying that episodic exacerbation and transient remission is possible in 46% of cases of Hellp syndrome. So if we if patient is of 34 less than 34 weeks of pregnancy, then doing such a premature delivery will again cause complication. So we can go with the expectant management. So, and also this expectant management extends the pregnancy until the maternal and fetal indication for delivery develop. So with the help of expectant management, pregnancy can be prolonged as much as 7 to 8 days. So there are some contraindication for expectant management, which are clinical feature of severe disease like hyperreflexia, persistent headache, confusion, and coma. Then severe biological abnormalities like very high LDH, bilirubin, uric acid, and creatinine. Then ultrasound abnormalities in fetus like abnormal umbilical, ductus venosus, Doppler indices. So during expectant management, the indication for delivery include uncontrolled blood pressure, deteriorating clinical condition like worsening right upper quadrant pain, confusion, and severe renal dysfunction. And also worsening thrombocytopenia or DIC, progressive worsening fetal monitoring parameter, and failure of platelet to increase within 98 hours is also an indication of severe disease with the risk of multi-organ failure and hence an indication for delivery. So HELP syndrome is not indication for cesarean section. So whether we should go for cesarean section or whether we should go for vaginal delivery, that call will be entirely taken by OBG, this obstetric and gynec department. So what as an intensivist, what we should be aware, what we should be taking care of, that if the patient is, if you are posting patient for cesarean section, then the platelet count should be at least more than 50,000. And there is no role of steroid except for lung maturation. Close monitoring is the critical post delivery to enable detection of deterioration and timely intervention. Such a monitoring include frequent blood investigation until starts improving. That means we should carry out blood investigation every 12 hours. When there are complications like hepatic rupture, failure, patient should be transferred to liver transplant center for assessment and management. Consideration of liver transplantation should be given to those with persistent bleeding from hepatic hematoma, rupture, or acute liver failure. The leading cause of maternal mortality in HELP syndrome is intracranial hemorrhage. It is reported in 26 to 64% of cases, followed by DIC, multi-organ failure, hepatic bleeding, or acute kidney injury. The recurrence rate of HELP syndrome is very high, that is 12 to 15%. So if we have some patient with the past history of HELP syndrome, then there should be proper counseling that this time also that patient can land up in the HELP syndrome, and that should considered as very high risk delivery. So this female should be counseled about the increased risk of cardiovascular and metabolic disease later in the life. So as I mentioned before, the very close differential of HELP syndrome is acute fatty liver of pregnancy. So it is very difficult to differentiate between these two conditions. So if I want like, but yeah, there are three features which so on the basis of which we can say this is HELP syndrome and not AFLP. So all the features are like closely like they are overlapping, but yes, if the patient is having polyuria, polydipsia, then it is more suggestive of AFLP. If the patient is having more acidosis, then again it is more pointing towards AFLP. If the patient is having more hypoglycemia, then again it is more indicative of AFLP. So if this so if you want to differentiate between HELP and AFLP, then you have to see this, look for these three features, that is polyuria, acidosis, and hypoglycemia. If all three are present, then it is more indicating towards AFLP. Otherwise, it's very difficult clinically to say whether it is HELP or AFLP. So HELP syndrome, so we'll see what are EASL guidelines for the HELP syndrome. So HELP syndrome should be considered as a manifestation of severe preeclampsia. So evaluation of severe serum liver test is recommended as abnormalities and are frequently associated with adverse maternal outcome in HELP syndrome, but they should not be used in isolation to guide care. Platelet transfusion should only be considered if the platelet count is less than 10,000, and this is associated with increased risk of abnormal coagulation and adverse maternal outcome associated with preeclampsia. So, for female with the preeclampsia, maternal assessment should include clinical feature as well as biochemical test as a component of multivariate mods. It is advised for female with the history of prior HELP syndrome should undergo first trimester screening to assess the risk of early onset preeclampsia, as this is likely to result in preterm delivery. So both of these as very strong recommendation. So next question, pregnant female with the prior history of HELP syndrome, does prophylaxis with aspirin should reduce the risk of recurrence? As I mentioned before, if the patient has history of HELP syndrome, then there are 15 to 20% chances that in this pregnancy also she will get HELP syndrome. So what we should do to prevent it? So the question is whether aspirin will help or not. So in the absence of contraindication, following first trimester screening for preterm preeclampsia, female identified at risk of at the high risk should receive aspirin prophylaxis commencing before 16 weeks of gestation at the dose of 150 mg to be taken every night until either 36 weeks gestation when delivery occurs or when preeclampsia or HELP syndrome is diagnosed. This has very strong recommendation and strong consensus. So female with the low calcium intake, either calcium replacement or calcium supplementation, that is 1.2 to 2 gram elemental calcium every day. It's suggested as it may reduce the burden of both early and late onset preeclampsia, but it has weak recommendation. So the next question is, female with the HELP syndrome, does prior treatment with corticosteroid, antihypertensive agent, magnesium sulfate improve maternal disease severity or reduce perinatal morbidity and mortality? So for female with the HELP syndrome that have non-severe hypertension, that is systolic blood pressure of 140 to 159 and diastolic blood pressure of 90 to 109, treatment should be initiated using oral labetalol, nifedipine and methyl dopamine. So, but females with the severe hypertension with systolic blood pressure of more than 160 mmHg and diastolic blood pressure of more than 110 mmHg should be treated urgently in monitored setting with antihypertensive therapy using oral labetalol, nifedipine, or methyl. Intravenous therapy with labetalol hydrolysine may be required. Magnesium sulfate should be given to female with HELP syndrome with coexisting severe hypertension to prevent eclamptic seizure, and it is also used as neuroprotective agent for preterm preeclampsia if delivery is required before 32 weeks of gestation. So, corticosteroid treatment should not be given to improve maternal outcome in HELP syndrome. High dose dexamethasone and betamethasone should be given as per national guideline only to improve lung maturation. If the pregnancy is complicated by HELP syndrome and if we are planning for delivery before 35 weeks of pregnancy. Now the next question is, pregnant female with the HELP syndrome or deranged serum liver enzyme imaging inform differential diagnosis, reduce maternal complication or impact on fetal and neonatal complication. Abdominal ultrasound should be performed in female with severe preeclampsia and HELP syndrome if there are symptoms suggestive of hepatic hematoma, abdominal epigastric and right shoulder pain. Clinician may be alert to be higher prevalence of hepatic hemorrhage hematoma in female with HELP syndrome and markedly reduced platelet count that is less than 20,000. So this is the diagram which is summarizing the management of HELP syndrome. So first thing is to identify. that is based on clinical features and lab features like urine analysis, full blood count, liver enzyme, liver function test, creat. This all we should check, and also we should go for the fetal assessment. Then we have to monitor it. Like again, we need to monitor BP. We should check for the proteinuria, abdominal ultrasound, and risk stratification. We should do properly. And for blood pressure management, so if the is systolic blood pressure if it is more than 140 but less than 160, if diastolic blood pressure is more than 90, then we can use the agents like labetalol, nifedipine, and methyl-dopa. For severe symptom like systolic blood pressure of more than 160 and diastolic blood pressure of more than 110, we can go with the IV antihypertensive agents and magnesium sulfate. Then we have to take the decision of delivery. So it is entirely based on the gestational weeks. If it is gestational week is more than 34, then we have to go for the delivery. If it is less than 34, then we need to administer steroid for fetal lung maturation. And yeah, we have to go for expectant management. And in this the things which we are including is stabilizing mother first. If high blood pressure, we need to treat it. Then if she is having showing seizure, then we have to treat with anti-seizure medication. And then we have to give corticosteroid for fetal lung maturation. So that's all. I hope you can manage the identify and manage the HELP syndrome properly after going through this. Thank you guys. Thanks a lot.